Welcome all to another awesome Department of Medicine Grand Rounds. I'm Allison Bond, the Director of Grand Rounds, and I'm really excited to introduce our speaker today, who's Dr. Adil Daud, who's a professor of medicine in hematology and oncology here at UCSF Health and the co-director of the Melanoma Clinic. He's a national expert on immunotherapy and melanoma, which is also his research focus. He's developed novel immunotherapies, designed and conducted phase 1 and 2 trials of these agents, and really has a special interest in immunotherapies with PD-1 antibodies and understanding resistance to PD-1 agents. So really excited to learn from you today, and I'll turn the floor over to Dr. Daud.
Excited to talk to you guys and be here. So my interest is in immunotherapy, and my disclosures are posted online. And so it's no secret to people that immunotherapy has been a huge, big thing, and it's been transformative. And, back in 2015, I want to say, the melanoma, the results in melanoma were first disclosed. And so all of these are like waterfall plots. So anything below that line is like patients who have had a response, and anything above that line is patients who have had tumor increase. So you can see that like melanoma, maybe about 70% of patients have had a response. But then if you go by, you could see that like head and neck cancer, it's like maybe about 50%. And then ovarian cancer, you could see that it's only about 20% of people who've had an actual response. And many people have progression of disease. Cervical cancer, or if you look at ER positive, HER2 negative breast cancer, that number is relatively low. And salivary gland cancer, that number is low. So just to give you a feel for what cancers respond and what cancers don't respond to immunotherapy, So it's not like every single cancer is uniformly responsive to immunotherapy. And so that has led to a whole active field of research. And one of the things that we've coincidentally also, or co-equally also know, is that T cell activation and T cell exhaustion is a real thing. And if you think about like when you get the flu vaccine, your naive T cells get stimulated by antigen, and then the vaccination is finished, or your flu is resolved. You have these memory T cells, and those memory T cells hang out for years and years, and that's the whole principle behind vaccination. And that's how we respond to infectious threats. But in cancer, it doesn't seem like that really happens to the same extent or to an appreciable extent. And it seems like in cancer, what happens is that antigen persists. And so because of the persistence of that antigen, you essentially have these cells that are just going at it. And so they get, what, for lack of a better word, we use exhaustion, even though I feel like that's an imprecise term. And really, it just means chronic activation. And so exhaustion kind of implies that, you've gone for like a 25-mile run, and then you're just kind of like, but that's not really, it's really a chronically antigen-stimulated cell. And so these cells develop checkpoints or breaks on their surface. And one of them is PD-1, which we are going to discuss at length, but also things like LAG3, CTLA4, TIM3, many checkpoints develop on the surface of the cells. And basically what happens is if you get these exhausted T cells and then look at it in a petri dish, you can't get them to secrete interleukin-2. You cut down on their cytotoxic activity. They won't kill tumor cells. And then they also don't produce tumor necrosis factor and interferon gamma. So that gradual process of exhaustion does happen. And that seems to be a basic fact about T cells in cancer. And so when a lot of our immunotherapy today involves essentially, taking out the breaks from T cells, either at the lymph node level, where there are all of these co-stimulatory checkpoints, things like CTLA4, et cetera, or in the tumor microenvironment itself, where PD-1 seems to play a major role. So with that in mind, let's pivot a little bit to the state of clinical data just to set the background for today. One of the important studies in our field has been this Checkmate 67 study, where patients with melanoma, right off the streets, untreated melanoma, were randomized to either getting like just a PD-1 plus a CTLA-4 blocker like nivolumab plus ipilimumab, or just nivolumab by itself. That's nivolumab as a PD-1 agent, or just the CTLA-4 by itself. So either the combo or PD-1 or PD-1 plus CTLA-4. So that was the thing with this study. And what it showed, and then this is just the latest outcome from the study, is that, very surprisingly, I think to many of us, the combination, and this is over 6 years now, results in 50% survival for stage 4 melanoma patients, versus about 40-something% for the PD-1 alone, and much less, 20% or so, for the CTLA-4 alone. And if you look at who's benefiting and who's not benefiting, different subsets and different retrospective analysis will show different stuff. So like if you look at BRAF mutation, which is about 50% of all melanomas will have BRAF mutation, you could see that for BRAF mutant, it seems like the combo really outperforms just PD-1. But if you look at non-BRAF mutant patients, which is about 50% also, the combo is better, but it's really very slightly better. So it's not like every single person needs that combo, or it's not like every single person is benefiting equally from that combo, as compared to just the PD-1 alone. And the combo, basically the downside is that it has a lot more side effects, and those are a special category of side effects, sometimes called immune-related adverse events. And they are things like autoimmune excitability, like things like colitis, like dermatitis, endocrine abnormalities, some rare but serious, like myocarditis and encephalitis, could be life-threatening, could be things like type 1 diabetes, which, it's not life-threatening necessarily, but it's a giant, big thing for a patient to deal with. So continuing on just the clinical data for a minute more, one of the other checkpoints on T cells is something called LAG3, and it's basically, the function isn't totally clear today, but it is expressed highly on T cells. It also seems to be expressed on liver and on cancer cells generally, and it's also present in the lung and present in the brain and in the gut. We don't fully know what it's doing in these organs. It's also present in the pancreas and in the heart. And so when people have blocked LAG3, it seems like you can get a fair amount of activity in patients with melanoma. And this just shows that if you have high levels of LAG3, it seems like you get more activity than low levels of LAG3, which makes sense because you're blocking LAG3. And if you look at the combination of LAG3 plus PD-1, that's the nivolumab plus relatlimab arm, you could see that you do get a benefit as opposed to just the nivo alone. And the benefit does seem to be prolonged. And if you look to see like who benefits from the LAG3 plus nivo combo, because that's the latest combo in our field, surprisingly, in the randomized trials, LAG3 expression doesn't seem to tell you whether you respond or not. And so it's been somewhat surprising in clinical trials and in immunotherapy, where the same exact biomarker that seems to be a super useful kind of way to predict success, when you look at the randomized trial, that biomarker kind of falls flat. And so you could see that if you had high LAG3 or low LAG3, that doesn't seem to make a huge difference. But if you had low level or high level PD-L1 expression, that seems to make a big difference. So for example, if you have high level PD-L1 expression, there's almost no benefit of adding LAG3. But if you have low level PD-L1 expression, LAG3 is tremendously, the hazard ratio is 0.68 versus 0.96. So it's one of these things that we are persistently seeing in immunotherapy, that the clinical data is complex, and it's a little hard to parse through and draw simple lessons. But having said that, I'm going to parse through and draw a simple lesson. But this is just keep in mind that this is just there's a lot of ifs, ands, and buts with this data. So basically, where immunotherapy is today is that if you on one axis, if you put the benefit in terms of progression-free survival in months median versus adverse events on the y-axis, this is kind of what it looks like. If you for single agent PD-1, you can get somewhere between 4 to 8 months, and that's for nivolumab or for pembrolizumab. That's the Keynote 006 study. Once you start pulling out the brakes, once you add more to it, you definitely get more months. But then, as you see on that y-axis, you also start ramping up the adverse event grade. So like for Nivo 3 AP1, you get about 30% grade 3 or 4. So that's like life-threatening side effects. And then if you go to the maximum, that's the Checkmate 67, high dose Nivo and AP, you get up to 60% grade 3 and 4 side effects. So you're talking some pretty serious adverse events. Now, I would say that, like, in the years since these checkpoints, back, in the last 10 years, one of the things we've learned is that you don't actually have to give everybody the whole, treatment. Like back in 2015 and 16, we would have people have bowel perforations because we would just keep going. We were so fixated on making sure everybody gets the full, full dose cycle of all cycles of treatment, that we'd be like, oh, you're going to the bathroom like 5 times a day, but why don't we just keep going? Well, if you keep doing that, you're going to worsen that adverse event. Today, we think that even if you get just a couple of cycles in, that's probably all you need. And I have many patients now who are like 10 years out, who really only gotten 1 or 2 cycles of immunotherapy ever and have a complete response. So I feel like the adverse event data has to be, because of the learning curve has been different. So having said all of this stuff, how exactly does it work, and what can we tell? So I think the first clue came from this PD-L1 expression data. And so if you look at tumors, and if you see like how much PD-L1 expression is there in tumors, and PD-L1 is basically the ligand for PD-1. So PD-1 is present on lymphocytes, and PD-L1 is present oftentimes in the tumor microenvironment. So if you just look at the tumor and say like, okay, let's take a look, there is a relationship. And if PD-L1 is totally negative, your response rate is probably going to be in the 10% range. If it's highly positive, like 4% or 4 plus or 5 plus, then you get this 60% response. And there's been a whole literature criticizing PD-L1 testing, much of which I agree with. It's just basically never going to be a red light, green light situation. It's never going to be one of those things where you could just say, oh, you're PD-L1 positive, like boom, you're using, it's never going to be that type of thing. It's always going to be in the light of that data. And what I've heard a lot from people is that even that 10%, why not just give it? And what's our plan B? And honestly, in melanoma, it's not like we have some great non-immunotherapy options. So I think that criticism is a reasonable one, but I mean, the data still is pretty good. So back in 2015, Mike Rosenblum, who was our colleague here at UCSF, said, why don't we just extract T cells from tumors and see whether we can look at the T cells if they're exhausted, see how their response is. And I was honestly pretty skeptical, but Mike was like, hey, let's do this for a few patients. So we did it for 40 patients. And I do think that it does show a pretty strong relationship. So if you look at, this group of patients, so this is T cells that are CTLA-4 and PD-1 high, you could see that there's definitely a much higher proportion of them in responders versus in non-responders. And if you look at some of the other groups, like the PD-1 and CTLA-4 low cells, so these are basically bystander T cells, there isn't a great relationship. And then if you look at things like regulatory T cells, and if you look at different subtypes of cells, not a super great relationship. And if you look at what is the outcome of somebody with melanoma who has a high percentage of exhausted T cells in their tumor microenvironment, we showed that in the discovery cohort, there was a pretty marked difference between people who had high exhausted T cells and low exhausted T cells. And then we did a further validation cohort. And so a lot of responders basically look like this second flow plot here. They have like really high numbers of exhausted T cells versus somebody like this who had like a progressive tumor in his neck. And you could see that this person has like a lower number of exhausted T cells. So when you hear this, you'll be like, wait, exhausted more T cells, like if more is better, like that doesn't even make a lot of sense. But I think that's just because the word exhausted kind of implies T cells that have run out of gas, but in actual fact, these are T cells that are tumor reactive, is probably a better way of calling them. And in the years since then, and this is just a very partial listing, what's been shown is that things like, it's not just the tumor, but it's extrinsically things like gender, obesity, tumor bulk, age, microbiome, like has an important rheostat function. We don't fully understand why gut microbiome is such an important player, but apparently if you take mice and rear them in antibiotic sterile conditions, you really can get checkpoint inhibitors to work great on them. Once you reintroduce microbiome, okay, then the checkpoint inhibitors start working. So there's a whole literature, and it's not totally clear whether it's a specific thing to one bug or a group of bugs, or it's just something that's important for T cells. And then, I would have said, more obesity, less function, but actually it's turned out to be the opposite, like more obesity, more function, maybe because chronic inflammation is engendered, and things like tumor bulk and gender seem to play a big role too. And one of the interesting things that we found is that liver metastasis has a very detrimental effect on immune response. And I'll delve into that in a second. But one of the other interesting things has been that if you look at a certain tumor type, like for instance, if you look at just skin, I had a Clinton Wu was one of our summer students who's currently doing his Hem-Onc fellowship at Dartmouth. But basically, when we looked at like different tumor types, they in a given organ, like for instance, if you look at skin tumors, and if you look at melanoma, Merkel cell, squamous cell, all in skin, they pretty much have the same response rate. And if you look at things like lung cancer, a lot of lung cancers, whether it's small cell or whether it's squamous or non-squamous, pretty much straight too. If you look at breast cancers, they're also, so there is a certain organ point that seems to be set for a given tumor type that is kind of surprising, but maybe there's some deep biology there. And if you look at mutation burden, so this study was done in patients with lung cancer back in 2015 by Rizvi et al. They looked at smokers versus non-smokers. And so it's interesting that the mutation burden in smokers is higher than non-smokers, which makes sense, makes total sense. And if you look at the response rate, you can see all the responders are in green and the non-responders are in red. And so you can see that the responders tend to have much higher mutation burdens as compared to the non-responders. And a lot of the high mutation burdens are all these magenta boxes. They're basically smokers, and non-smokers tend to have lower response rate. So this kind of set into motion this whole idea that these neoantigens or like mutations that are created by mutagens like smoking and ionizing radiation, etc., are one of the things that the immune system needs to have to drive that immune recognition. And back also, like now about I want to say 10 years ago, Mike or Max Trummel and Miranda Braz, his postdoc at the time, ran these studies on melanoma patients, and basically found that in order to get the T cells, the exhausted T cells into your tumor, you basically needed to have these dendritic cells, like cross-presenting dendritic cells in the tumor. So they seem to set the stage for the T cells, or drag them in, or cause them to get into tumors. And if you look at the responders again, the green the green bars here, they basically have this one specific kind of dendritic cell called classic DC1s that seem to be needed for the T cells to come in and to drive tumor rejection. And so Max has done a lot of work on this, and then basically posits this model where you essentially get natural killer cells, which are kind of an innate cell that's in our microenvironment. And then those guys drive DC1s. And there's other methods of doing this too. But eventually you get CD8 T cells, and then that gets you your patient who might have a response to immunotherapy. And then he's also shown that DC2s in some cases that are set off in tumor types like head and neck cancer can also lead to immune sensitivity. And so here in this cartoon, there's only, there's the class 1 types of responders, like people like who have melanoma, et cetera. And he has a class 2 responder type. But honestly, this is just a very partial, probably there's many different responder types. And we know that because if you look at response duration by cancer, you could see that like in somebody with melanoma, the response duration is probably unlimited, or years long. You don't even know for sure how long it is. The median duration of response is indefinite. But in like lung cancer, the duration of response is a few months. So it's not like every single response is equal quality, and the response quality seems to vary a lot, from tumor type to tumor type. That has, again, further complicated this job of trying to figure out like how exactly do PD-1 drugs, work. So one early piece of data this was from the Merck clinical investigation team. They did this study where they looked at nanostring profiles on patients, and they came up with what they call an interferon gamma profile. So it's just like interferon gamma and genes that increase interferon gamma in tumors. And what they showed is that if you were a non-responder, you had lesser interferon gamma or interferon gamma pathway genes compared to a responder. But when you look at this, you'll see that there's a lot of the whisker plots are pretty, it's not a very tight kind of distribution. And the most you can say is that if you are low interferon gamma, you're unlikely to be a responder. But if you're high interferon gamma, you're not guaranteed to be a responder. And that's what this shows, that all these red dots are responders and the black dots are non-responders. So once you cross a certain threshold, your odds of becoming a responder increases, but by no means guaranteed. But when you're below that threshold, certainly very low likelihood of your being a responder. And the interferon gamma profile, interestingly, is very similar to a different signature that was discovered years ago called a tertiary lymphoid signature. And so what are these TLS, or what are these tertiary lymphoid structures? It's one of these scientific curiosities, and one of the interesting pathways in how immunotherapy has evolved. So years ago, investigators at Moffitt Cancer Center, Domenico Coppola and Jim Muley and others, showed that if you look at cancers, like in this case, they looked at just colorectal cancer. If you look at cancer pathology, you can see these tiny little follicles inside the tumor that on H&E just look like little round balls. But when you do special stains, they stain positive for B cell markers like CD20. They also stain positive for activation markers, T cell markers. So they seem like mini lymph node-like things, but of course, but not in the lymph node, but actually in the tumor type itself. And then if you look at, if you do a nanostring profile in these, for these tertiary lymphoid structures, that actually matches the interferon gamma signature that you see in immunotherapy responders. So kind of, surprising that this came together. And in the last, I want to say 5 years, it's become pretty clear that in order to get a great response to treatment, you kind of need to see these TLS or tertiary lymphoid structures, or to rephrase it, if you have a tertiary lymphoid structure, there's a higher chance of your getting a response. And then this data is from kidney cancer, but honestly, it's true in multiple other types of tumors too. It's true in melanoma. It's true in lung cancer. And so the exact point of the TLS isn't totally clear. It could be that you need B cells there to either prime T cells. That's one theory, or the B cells are generating antibodies, and the antibodies in some way are needed to make your T cells respond to the tumor. There's still a lot of debate on what exactly is going on, why you need B cells in that cluster to really generate an immune response. And so this is the model that Kristen Pauken proposed, but which I think makes sense, which is that you have this like flux between your peripheral lymph nodes, etc. And when you you have exhausted T cells in the tumor, and then once you block PD-1 or PD-L1, essentially these tumors inside the T cells inside the tumor start killing tumor cells, but they have a finite lifespan and don't last. They're epigenetically programmed to only go so many times, and then you need fresh flows of T cells from your lymph nodes. And that's how some of the data makes sense, that in terms of what we are seeing, that these T cells don't have an indefinite lifespan. So how come you have short-lived T cells, but you have long duration responses, right? That is a major question in our field. Like what exactly is happening? I mean, do you have like some long-lived cells somewhere that are, driving all this stuff? So I'll just leave that question hanging for a second to just talk about one other kind of interesting side note on immunotherapy. And that is that if you take a person with metastases throughout their body and try to categorize them, look at patients with lung mets or versus liver mets, one of the interesting observations in the literature has been that patients with liver mets seem to do a lot worse than people who have any other permutation of MET. So this is a paper that we published back in 2016. And essentially, if you look at the liver mets, that's this lower line here. That's the liver plus lung minus group. And this is data from UCSF, UCLA, and Angeles Clinic. So just the West Coast, this is back in from about 10 years ago now. And what we found is that the progression-free survival was only 2.96 months versus for people who had no liver mets, lung mets, it was like 23 months. So there's almost a tenfold difference just based on the site of disease. And a lot of work has been done. And if you look at some of the randomized studies like Checkmate 67, you could see that all of those lines go down with liver metastasis. You could see that whether you're using combination IPI plus Nivo or just the Nivo or just whatever you're using, all of that has a bad response. And so when we submitted this paper initially, what we heard from the reviewers is that, hey, you're just talking about the liver microenvironment primarily, but what if somebody had like skin mets or lung mets and liver mets? Can you show us that the microenvironment in the non-liver mets has less T cells? And so we did this study. We actually, Hopkins surprisingly had patients who had sub-Q mets and liver mets coincidentally present in the same patient. So we basically got those tumor samples and then stained them. And essentially what we found is that even if you look at the non-liver mets in patients who had liver mets, so let's say you liver plus skin, if you look at just the skin mets, you could tell because even the skin mets had fewer T cells in them than the liver. So kind of suggesting that this is like a systemic immune suppression, not just a thing that has to do with the organ itself. And in the years since then, Jeff Bluestone, who was here until recently, and James Lee, who's a young investigator at that time and still a young investigator, has done this experiments in mice showing that in mice, if you create a liver met plus a non-liver met situation, you can basically create that same kind of thing as you're seeing in human beings with liver mets. Like you basically suppress the immune system, and whether it's through Tregs or myeloid cells, you get this like reduced immune infiltrate, and they've done a lot more work since then too, suggesting that there's some kind of complex biology there that we are only beginning to understand. A group from Michigan recently also reported on this, and they essentially found similar stuff as we showed here, and essentially showing that liver mets, in some ways, reduce the response rate of immunotherapy. And I think I counted I think there's been 150 publications maybe in the immunotherapy field since that 2015 paper, just showing that it's true in bladder cancer and lung cancer and breast cancer and many, many other types of tumors. So it isn't just melanoma specifically, it's just a liver met problem globally. And I'm just going to skip over. So current immunotherapy basically relies on your immune system already mobilizing against the cancer. So you have to have a tumor that has these exhausted T cells in place. So what happens if you don't? What happens if you have one of these lower T cell infiltrated cancers? And so one approach has been to make cancer vaccines, and I'm not going to belabor this point except to say that cancer vaccines have been disappointing over the years. We've tried all kinds of different cancer vaccines, really haven't panned out. But one approach that we haven't used before, which might be the thing, has been to use these neoantigens. So I was talking about smokers, having neoantigens, because of because cigarette smoke is mutagenic, and so you have these neoantigens. Well, it's known that melanoma has a lot of neoantigens too because of the UV damage that's created on your tumor cells, and so that generates neoantigens. So those neoantigens, we could sequence tumors. We could potentially, using RNA, mRNA technology, package them in a lipid nanoparticle, just like with the COVID vaccine, and use those. And so this study was done in melanoma, and it was called Keynote 942. There's been so many keynotes done since then that that name is maybe overused. But basically, patients with melanoma were randomized to either just PD-1 by itself. That's the blue arm here, versus the mRNA vaccine plus PD-1. And the primary endpoint here was relapse-free survival. And to my surprise anyway, it seems like it's pretty effective. If you look at relapse-free survival or recurrence-free survival, that was the primary endpoint. You could see that the recurrence-free survival was a lot better with the vaccine versus the PD-1 alone, and the hazard ratio was 0.56, which is pretty amazing. That's about a 50% better outcome. And if you looked at distant metastases, also seemed like it was better. So another big kind of use of immunotherapy in our field has been to move it earlier pre-surgically. And again, not totally clear what's going on, but there's two approaches in cancer. Either you take the tumor out and then you do the treatment, or you do the treatment first and then you take the tumor out. And so that's just these two different approaches. And oncology loves jargon. So adjuvant is when you do the surgery first, and neoadjuvant is when you do the immunotherapy first. And so there's been a couple of trials showing that surprisingly, this second approach, the neoadjuvant approach, seems to give you better outcomes, even in terms of things like survival, which is on the face of it kind of hard to understand or explain. And for example, if you look at SWOG 1801, and this is a study where patients with stage 3 or 4 melanoma are randomized to either have the surgery first, followed by 18 cycles of pembro, or 3 cycles of pembro, followed by surgery, followed by 15 cycles of pembro. So really a clean experimental design where everybody gets 18. It's just 3 plus 15 or just 18 all at once. So no, not that you're giving more treatment. And to my surprise, event-free survival seems like markedly better in the neoadjuvant plus adjuvant arm compared to the adjuvant arm alone. So, and if you look at 2-year and 3-year event-free survival, it seems like that benefit seems to be, prolonged. And if you look at overall survival, not yet statistically significant, it's 0.06, but clearly going in the direction where it might be statistically significant at some point. And so really leading to some questions as to what exactly is the detrimental impact of surgery. Why is surgery detrimental first or versus not, afterwards? And the Europeans and Australian group did this trial called NADINA that, in my opinion, is a lot more convoluted than the simple SWOG 1801 and really hard to parse through. But basically, what they did is the patient with stage 3 or 4 melanoma get 2 cycles of ipi-nivo versus immediate surgery or total lymph node dissection, and then followed by adjuvant immunotherapy with nivo alone. But the details are pretty complicated with this trial design. And what it did show, though, is that if you do the neoadjuvant immunotherapy, you do get a much better result. And the hazard ratio you can see is 0.32. So really a massive benefit for upfront immunotherapy versus post-op immunotherapy. And I'll maybe just add like a note here to say that, a lot of times we have this question, like when somebody is having a response radiologically, what is actually going on? And so what they did in this NADINA trial is they looked at pathologic response. So like when you had surgery after the immunotherapy, they looked at the lymph nodes and looked to see, what percentage of people were having responses and compared it to the radiology response. And what is interesting is that, for instance, if you take people who are radiologically have stable disease, so meaning the lymph node didn't shrink, but didn't increase in size either, but stayed the same. So it's this group here, the radiologic SDs. And if you delve into what happened at the pathologic level, because now you've got the radiology pre-surgery and then post-surgery, you have the pathology. One of the interesting things is that a lot of people who radiologically have stable disease, pathologically really have no tumor or have had either a path CR, which is that dark green bar here, or a near path CR. So kind of showing that what you're seeing structurally as being the tumor, or which is the tumor, when at the pathologic level, there's no viable tumor cells left. And if you take patients with a path response or a near path response, that's a dark green line there, basically everybody seems to do well over time. Now, the devil is always in the detail in medicine. The question is, what exactly is a path response? And this is Michael Tetzlaff's slides, who shared them with us. And so we are having a lot of patients get the neoadjuvant therapy today in our clinics. And so when the tumor comes out, the question is this a path response or near path response? And part of the issue is that, what exactly constitutes a path response? So if you see like a sliver of tumor on the side with just necrosis versus hyalinized fibrosis versus, proliferative fibrosis versus this thing here called melanophages, which is basically dead tumor with the pigment taken over by macrophages, which then look, to the uninformed person like there might be tumor cells, but really it's just pigment in the macrophages. And so so you have now the pathologist has their task of trying to figure out what percentage of this tumor nodule is viable and what percentage of it is dead, and what exactly constitutes a response, because so much depends on whether we continue with treatment or not. So if you remember from the NADINA trial, it's the people in the neoadjuvant therapy arm only got 2 cycles of treatment pre-surgery versus the other guys who were getting surgery followed by 1 year of adjuvant therapy. So you're getting much less treatment in the neoadjuvant arm, but if you call that person a path responder or a near path responder, you're putting that onus on the pathologist to really tell you whether this patient has a path responder. So every week we kind of struggle with this issue of like what exactly is a path responder, because obviously the patient is super worried and is wondering if they're going to get more treatment or not. Are you really going to? It almost seems like 6 weeks of treatment is too brief for something, after you've told people like, well, this is really so. I think this is Michael's slides. He thinks that, like in some cases, hyalinized fibrosis and some of these things show better response than some other, and we have 2 to 5 year data suggesting that certain types of path response are beneficial. So in the last few minutes, I'm just going to pivot to a story that unfortunately does not have a great end, but I'll just tell you what we've done so far. So, many years ago, we had this idea of, using interleukin-12, which is a cytokine that gets T cells into tumors and also helps T cells and dendritic cells communicate. And so we came up with this idea, or I should say Rich Heller came up with this idea. I was kind of like collaborated with him. And so the idea was that you would basically inject this directly into tumors and then use electric pulses to get the interleukin-12 into tumors and get the in a sense get the tumor itself to become. And so this is in the pre-PD-1 era. So we had I want to say 4 patients out of 22 who had great responses. And the one that really got to me was this guy who was like 65 at the time. He had a ton of melanoma tumors on his right chest and on his back. And you could see all these in-transit nodules on his chest and on his back too. And so we injected only 4 of them, and you could see the stickers there. And so I honestly didn't think much of it until about a year later, when I noticed that a lot of the tumors were fading away, and the ones in the back were also fading away, which we hadn't even done any direct treatment on. And by year 2, pretty much all of the tumors had flattened out. And I biopsied, I want to say 10 tumors. And we published this data. Essentially, what was seen in those little black spots on his chest and on his back was just a lot of like pigment cells, melanophages, like we were talking about with the path response, but not living tumor. And you could see that, it was like this slide D, and if you did T cell staining like in G and H, you saw a lot of CD4 and CD8 cells in there in that nodule. And this was in the pre-PD-1 era, so there was no PD-1 involved. So this is just single agent electroporation of IL-12. So I was pretty excited. And then we did a phase 2 trial, and this is one of Alan Al-Ghazi's patients. And what we were able to show is that both the treated tumors and even the tumors you didn't treat, the ones that you didn't do all this electroporation stuff in a certain percentage of cases, they had a resolution. And then this gentleman had a bunch of tumors you could see on his face. We electroporated him, and then he had a nice response. But then I want to say 6 months later, he developed a parotid swelling, and you could see that parotid swelling right here. And this was around 2012 or 13 when we had one of the PD-1 trials open up, and we actually put him on it. And to my knowledge, he's had a response, and he's still disease-free even at this point. And so we've done many other trials using this technology. And Mike Rosenblum, I was talking about the assay that we had, the T cell assay. So we decided to do a study using the T cell assay where we took patients who had low levels of T cells in them, like the red, this group here, where T cell content of tumor was low, and just to see if we could make those patients respond. And yeah, we had like a 43% response rate in patients, who had and you could see that the patients were chosen to have a low T cell content, and that's why they have like 2% and et cetera. And, some patients had this was a patient who had progressed on PD-1, and he had a ton of tumors on his left leg. And initially with this technology, you did get some increased redness and pain and swelling. And then over time, in some cases, you could see the tumors resolve. But what was really interesting and kind of disappointing for me was that I had thought at that time that if you could just look at the tumors, you would be able to predict who would respond and who wouldn't respond. And when we started looking at the tumors, these are just two examples. Like if you look at a patient who had progressive disease versus somebody who had a CR, complete response, you could see that even the person who had progressive disease had a tremendous T cell infiltrate after the IL-12 treatment. But obviously it didn't work, and the tumor continued to grow, versus this person here who had also had a great T cell response, but had a complete response. So I think that is just, to me, always stands as a reminder that, the T cell infiltrate, yeah, sure, it is a critical thing, but is it, or it might be necessary, but not adequate to get a response, or it doesn't always correlate with an actual response. And then in the years since then, this was a trial that was done worldwide, and you could still see the abscopal responses. So this was a patient who had tumors in the lung and also on his face. And I want to say this patient was treated in upstate New York, like in Roswell Park, and you could see that tumors were treated on the face, and his lung lesions responded, and his face lesions responded too, although not at the same time. So to end, I'll just say that PD-1 agents, yes, they're super effective. They're incredibly active. I think I counted 27 approvals in the years since 2012 when we started the trials, and for patients who don't have active T cell infiltration, that's where the challenge is, which is honestly the majority of tumors. And so not just in melanoma, it's about 60% of patients who don't have T cell infiltrated tumors. But honestly, in most other cancers like salivary gland cancers and head and neck cancers, it's only 20% who have T cell infiltrated tumors. So there, I think we are still at a loose end. And whether it's an active immunization strategy or some other bispecific antibody, not totally clear to me what the best. I think that vaccine study is pretty interesting, but we'll have to see if that really pans out in randomized phase 3 trials. I think that the jury's out, and I think in the next few years we should find out if that really works. But and as I just mentioned with that IL-12 study, the tumor microenvironment is super complex, and it's been hard to really wrap my head around what needs to happen for a response versus in cases where you have your T cell infiltrate come in, but still have the tumor happily, continue to grow. So that I'm going to end and take any questions if anybody has them.
Thanks so much. Couple questions to start us off, and then I'll throw it out to the audience. So you mentioned all of these things that, frankly, I'd never heard about before, like the mRNA vaccine, the intralesional or the plasmids. What is kind of next up in terms of people really using it in the real oncologic treatment world, do you think, of those options?
I think it's a evolving field, in terms of the neoantigen vaccines. I think before neoantigen vaccines, we've done a lot, we and many other people have done research on shared antigen vaccines and what are known as cancer testis antigens. Those are the two major categories of vaccines, And in phase three trials, they've failed. Like they've looked promising in phase 1 and 2, but failed in phase 3. I think the issue with the neoantigen vaccines is that is the effect that you're seeing in some of these early studies because of the neoantigen itself that you put in, which, there's some questions about, versus the actual vaccination itself. There was a paper by a radiology resident at MD Anderson, Adam Griffin, who basically looked at people who had COVID vaccines and had cancer treatment, and somewhat surprising. And this is data from MD Anderson, so take that with how you will. Basically showed that even people who got COVID vaccines had better survival outcomes than people. But of course, it could be that if you didn't get the COVID vaccine, this is at the time of COVID, so it could be that your life was shortened, not because of your cancer, but because, so there's a major question about that data. But in some models, it seems like even non-specific vaccines and even RNA capsulated, COVID or the vaccine nation itself seems to cause some type of immune response. So because the control arm in a lot of these studies is just, it's not a sham vaccine, or it's just saline. So you're not getting that sham vaccination, so to speak. So whether it's your secret formula that is prioritizing you, whether that's the thing, or whether it's like the vaccination, itself that's causing. But I think, I personally still think in situ, using the tumor as a lymph node, or if you can convert a tumor into an immune organ, that was the theory behind interleukin 12. I still think so, but it's an incredibly complicated thing to do. And here at UCSF, yes, you can definitely get your act together. But is that what I've heard from a lot of people is that, just the nature of medicine is such that, for people to do this is not, practical, for lack of a better word. And
sure, might require resources elsewhere that aren't available, and expertise and things like that potentially. Yeah. Okay, that makes sense. And then just, you had mentioned some of the testing doesn't necessarily correlate with treatment response. And so when you get a new patient in your clinic, like how do you decide what treatment to put them on, and how do you kind of counsel them about the decisions that you're making?
I think that's a super, super interesting and super complicated question. I think there's the tools that we have, like the tumor mutation burden and PD-L1 testing and the interferon gamma signature, still, even at the end of it, don't really tell you for sure whether somebody's going to respond to like just pembro or a combination of something. And so we're back to just using clinical judgment, which is, i.e., how you feel, and how extensive the disease is, and if somebody has brain mets. I personally think if you have liver metastases or some super extensive disease, then you probably need to use combination immunotherapy, and to talk and say like, hey, your response rate is going to be higher, but also we're increasing the likelihood that you'll have more adverse events, which could be life-threatening in some cases,
So do you get that PD-1 testing on everybody?
I do.
And then you just kind of have it, and it may or may not affect what you give them. Is that
right? I do, because I feel like it does tell you something about the tumor, how immunogenic it is and how T cell infiltrated the tumor is. But the criticism I hear a lot nationally, and why it's not used nationally, is because people have said, well, what do you, just the previous question that you had, like, are you really going to use the PD-L1 testing to deny people immunotherapy, versus what is your plan B if somebody has low PD-L1? If you're going to be back to square, just giving people combination immunotherapy anyway, then what is the? But I feel like you're informed,
Sure. Yeah. No, just curious. Great. Got a couple questions here. Just if you wouldn't mind saying your name.
Oh, of course. Yeah. Mark Anderson, professor in the Diabetes Center and director of the Diabetes Center. So Adil, congratulations on all the incredible work you're doing in getting immunology into the clinic. But, I think one of the big picture things I see with all of this is there's so much to learn about what is exactly going on with the immune system here. And a lot, there's still a lot that needs to get dissected out. I think one of the most challenging things is in most responders, even now, we don't have any idea what the T cells actually saw.
Yes.
You agree, right?
Yeah, totally.
Right. T cells are a huge pain in the, being an expert in T cells, they're just a huge pain in the butt when it comes to antigen specificity, especially at an individual patient level. Right. But one question I had coming back to what I heard was the adjuvant versus neoadjuvant story. It doesn't shock me at all that, taking the tumor out, right, is actually hurting you in terms of getting the immune therapy going because you remove the antigen. Right. Yeah. You have to think about the whole thing as an immunologist, not as a cancer person. Right. You're trying to prime a huge immune response against the cancer. So one of the questions I had that I didn't see the data for is in the neoadjuvant, what's the incidence of vitiligo downstream compared to adjuvant? Right. So you would predict that if you're priming a great immune response against the melanoma by doing the pembro up front, right, you probably see more vitiligo downstream of it because it's a surrogate readout of it.
True.
Do you know the data on that?
I don't know the data on that, but I'll just say that, and for those of you who don't know, Mark has done a lot of really great work on defining tolerance and has discovered like novel methods, and we have an active collaboration. What I think the one, I just anecdotally, I had this one patient who had, I actually had her neoadjuvant therapy like years ago before this data. And basically, she had a great response. And then after we took the tumor out, post-operatively, after the tumor was taken out, she basically developed type 1 diabetes. And even to this day, she's been seen in your clinics and has type 1 diabetes and has had no cancer recurrence, but every time she sees me, she's like, I wish you didn't do this. I'm like, but it's we're learning from you, but if I'd known that, it would do that. But I've seen that happen, that when you take the tumor out, you seem to you seem to cause more autoimmune problems. Like I've had patients develop, different weird kind of autoimmune toxicities post tumor resection. But actually, I should look. Maybe we can look at the vitiligo and see, because that would suggest that you're further upgrading, creating a whole new level of autoimmunity, right? Yeah. Hey,
Adil, great job. Andre Goga, Hemonc Medicine and Cell and Tissue Biology Department. So one thing you didn't really mention, although you kind of mentioned that you had patients, decade or or more later. What's your experience with late recurrence? And are you thinking about this as sort of acute leukemia that if you get out past 3 or 4 years, you're probably cured, or are you still seeing a lot of patients a decade later that are recurring, and what does that look like?
I don't know if we have a ton of patients who are 10 years out. We like of the patients we have that are like in the 5 to 10 year period, we have seen some late recurrences, and in some cases it's been recurrences in the brain, and in some cases it's been like liver recurrences. And what I've done is in the 2015, 2016 period, that time, if somebody had a response to like pembro, I would just give them pembro again, thinking that maybe there's something about. But in the years since then, I've learned that if you do that, you don't get quite as good of a response that second time around. And so I've been using more heavy duty immunotherapy. And I want to say that almost everybody who had that awesome, complete CR, when you retreat them that way, it's that patient has gone back into remission. Now, I don't know if that second remission is going to last like years, or is it just going to be a short duration? But I think in terms of that second remission, I think the longest we have somebody is like maybe about 2 years from that second remission. So not a total slam dunk, but a complete response is going to stay durable like 95% plus of the time. If you look at 5-year data, the 10-year data is just not there yet today. I mean, I think we first started, I mean, we were amongst the first to start. That was back in 2012, was the first patient on PD-1. So it's been time, but from the date of the CR, we haven't had that much time, you know? So and if you look at lung cancer, et cetera, it's not quite as rosy a duration of response. Like even people who have complete, I also think that because you're doing a chemo plus immunotherapy combo, not 100% clear what that response is to. So it could be that in some cases you're just simply getting a lower, quality response.
Great. Well, thank you so much. And thanks for everyone's attention. See you next week.